superficial components. So the deep drain the internal organs and run with the deep arteries. Lymph flow is unidirectional. There's one-way valves. And so your right head, your neck, your right upper extremity, and your right upper torso are draining to the right lymphatic duct, and your left head, left upper extremity, and then your right and left lower torso, and then your bilateral lower extremities are draining to the thoracic duct. Ultimately, the lymph is draining into the subclavian veins. So the different ways that lymphedema happen, you can either have a large volume output that the lymphatic system can't handle, and then you get lymphedema. So examples that I gave was post-operative kind of orthopedic patients, but I actually had, well, mine was a combination. I had some pretty bad lymphedema after I had my twins, which was sort of a combination of large volume output. You know, you have a high circulating volume when you're pregnant, but also it was also more of like a mass effect with the twins on my lymphatic system. So you can also have primary and secondary defect in the lymphatic system. This will also lead to lymphedema. And actually, the majority of our lymph nodes in our abdomen, over 400 lymph nodes in our abdomen. And then we actually have the other kind of, you know, high concentration of lymph nodes are in our head and neck as well. So ultimately, if this fluid isn't moving, this interstitial lymphatic fluid is kind of sitting put with the swelling for long periods without any intervention, you're going to get the subcutaneous fiber adipose production, the very kind of hard tissue. This is a chronic condition, but typically not life-limiting. That being said, I have patients who are in the vicious cycle of lymphedema begets cellulitis, begets more lymphedema, and we know cellulitis can turn into sepsis. A lot of my patients have been hospitalized. The natural disease course would be to worsen without intervention. And, you know, it's really not painful. It's like a heaviness. It's an uncomfortable feeling. You know, it can be distressing. The people who are saying pain, I'm thinking about other things, perhaps. You can definitely have functional impairments, limited ambulation, activities of daily living, which I certainly had when I had lymphedema. Lymphoria is actual leakage of the lymph fluid. And it looks like, well, I have a picture coming up. It's like a clear fluid. Like I say, it's like rain. Cutaneous ulceration is not typical. So if there's cutaneous ulceration, you're thinking more of that there's a venous component. That being said, there's a school of thought, which we can kind of emphasize at a later point, that by definition, if you have chronic venous insufficiency, you also have lymphedema, because embryologically the lymph vessels and the veins are developing simultaneously. So that's called phlebolymphodema. We'll kind of come to that in a bit. Like I said, there's a 9-fold increase in developing cellulitis, which can obviously, God forbid, lead to sepsis. So some visuals we're going to start with. The A, which is the top left of the screen, this is a pediatric primary lymphedema of the left lower extremity. So primary lymphedema, there's an error in the development of the lymphatic system. So it can present kind of at birth or, you know, childhood, adolescence. And there's actually lymphedema tarda, which is primary lymphedema that develops more in adulthood. Yeah, pretty rare in children, 1 in 100,000. That being said, I do see children in my practice. Like I said, you can have newborn onset or childhood or adolescent onset versus secondary, an injury to the lymphatic system. So in the whole world, the most common is filariasis. We do have filariasis in the Americas, in Haiti, Dominican Republic, Brazil, and Guyana. But mostly kind of in the West, so to speak, the secondary lymphedema is due to resection or dissection of lymph nodes for cancer treatment, radiation during cancer treatment, or penetrating trauma. And usually it's typically within the first 3 years after the injury to the lymphatic system, although it can be up to 5 years later. So just to go back to our images, B is secondary lymphedema of the right arm in a patient who had breast cancer treatment. C, secondary lymphedema of the right leg following inguinal lymphadenectomy and radiation for cancer treatment. So they probably had some kind of pelvic cancer or like urological cancer, perhaps. And then lastly, we have D in the far right, bilateral lower extremity obesity-induced lymphedema in a patient with a BMI of 72. I actually have quite a few patients with BMIs over 70. A BMI of over 50 puts you at very significant risk. I kind of want to gloss over, I want to talk about lipedema and I don't want to talk about lipedema. This is one of your differentials. It's one of those things. So this seminal text, this is a really good text, lipedema, the disease they call fat. It's like a very slim volume, but has everything. So if you want to do a deep dive, I highly recommend. I'm seeing this more in my practice. There's some really good guidelines that are out there also that are available. But whoops, sorry. Oh, hold on. How do I go back? Hmm. I don't know. Oh, is it just really lagging? Hold on. There we go. Sorry. Okay. So people who have a large amount of subcutaneous fat in their upper and lower legs due to actual like hyperplasia and hypertrophy of the fat cells, the adipose cells, sort of complex pathophysiology. It's almost wholly in females. This is a clinical diagnosis. So you're training your eyes. You don't really need extensive imaging. The lymphoscintigraphy that you do for lymphedema is normally normal. Obviously, you have to rule out you'd want to rule out that maybe it's actually lymphedema or it's some kind of systemic disorder. Another thing to consider for women, particularly, is the kind of gynoid versus android, body composition. So some women just have that very, it's like the apple versus the pear. And you can just have very kind of pronounced pear shape, but not really have lipedema. So things that you'll notice in these patients, the things that would clue you think it might be lipedema as opposed to just like their personal fat distribution is the cuffing that you see at the ankles. It's like cuffing or pantaloon sign with kind of very skinny feet. The kind of initially maybe stage 1, you can see like their legs are almost like columnar like. There's also what they call the two body appearance, that you have a very slim torso and very big legs, and you have a very dramatic waist to hip ratio. So other things that you're looking for. So if you have lipedema, you might also have superimposed obesity, and then you also are at risk of lymphedema as well. Coding can be a bit tricky. I don't know. There's definitely codes in Epic right now. It's not a huge issue for me. I think we talked about these already. In a pure lipedema, the stemmer sign is negative. We'll talk about stemmer sign, which is pathognomonic for lymphedema. But that's when you pinch at the base of the second toe. You should be able to pinch. If you can't, that's a positive stemmer sign. Also, these patients will report to you spontaneously that they have very like their skin is very tender. Sorry about the barking. Very tender. They might have like I said, the tissue maybe kind of granular, sandy, nodular. Sometimes that's a little hard to appreciate, but they will tell you that they are very tender and bruise easily. And then, like I said, there's a hormonal effects which can happen during pregnancy and menopause. Okay, let's get to some lymphedema. Lymphedema staging, 0, subclinical, and what I kind of prefer to say is that patients are at risk. When patients are stage 0, I kind of like to maybe more highlight if they're at mild, moderate, or severe risk of, getting more clinically presenting lymphedema as opposed to subclinical. Stage one, stage one lymphedema typically subsides with elevation, so very mild. Could be pitting. Yeah, maybe yes, maybe no. There's 2A and 2B. That's the bulk of my patients. So 2A, you're going to have pitting. The swelling is going to kind of be there all the time. It's not going to go down overnight. 2B is this mix. I actually had a patient recently who was this classic 2B of like a little bit of pitting, a little bit of fibrosis, right? The hardening because it's been there for a while. And then 3, I have had some 3s. Typically, anybody who has the papillomas, which are the warty overgrowths, which you'll see in a second, I consider them to be stage 3. It's harder to treat, to do complete decongestive therapy because, their edema is very fibrotic at this point. There's no more pitting. Actually, I say to patients, I think pitting distresses patients, but pitting's a good thing because it will be like pretty responsive to lymphedema therapy. Fibrosis is tougher, literally and figuratively. So I said you can have lymphedema in your upper and lower extremities, typically more distal, and then it can progress proximally. Pitting can start at stage 1, but stage 1 typically will go down overnight or with elevation. We said the stemmer sign is pathognomonic. That being said, you can have lymphedema and not have a stemmer sign. But always check, you pinch. You should be able to pinch. That's normal. If you can't pinch, it's a positive stemmer sign. Right, where this is a circumferential overgrowth, so we're measuring with a tape measure around. You might see clues like scarring, which suggests surgery or radiation. Typically, we don't have ulceration unless they have a phlebolymphodema and they have a component of venous stasis or chronic venous insufficiency or venous hypertension. BMI over 50, but really any like obese BMI that added weight. And then you might see the lymphoria. We'll have pictures of most of this coming up. Pitting, I feel like we tend to like overscore pitting. I don't know, but yeah, this is, just score your pitting. It will, when I have learners, I'm always like telling them be as descriptive as possible and detailed as possible in your physical exam. So, yep. Most of us are comfortable with that, I would say. All right, so fibrosis, papillomatosis, hyperkeratosis. So fibrosis, like I said, it's that progressive thickening, scarring, hardening. There is the fibrous connective tissue in the skin and the superficial tissues. It grows, it proliferates. As I said, very hard. It kind of builds up. If there is just the pooling, the swelling of the protein-rich lymphatic fluid. And it definitely leads to kind of issues with skin integrity and a lot of complications. Skin will break down more easily if it's fibrotic because it feels hard. You think it's stronger, but like, no, it has no give, right? You can get bacterial infection, cellulitis, which we said is very risky. And then actually can be more difficult to treat because of the lack of circulation and fluid movement in that limb. The papillomas that you can see are the warty overgrowths or benign overgrowths of the skin papillae, the extensions of the dermis into the epidermis. So it kind of looks like bubbly. They're actually highly vascularized. They bleed easily. Patients will tell me that they bled. They can be a source of infection, obviously, if they are open. And then the papillomas can become fibrotic. So this is really bad news. I mean, you can see this is bad news. Hyperkeratosis, overgrowth of the epithelial layer of the skin. Just kind of that granular layer builds up. Like I said, this contributes to kind of maladaptive skin changes. On the toes and the feet, you can kind of get calluses. On the shins, you're getting like dry, flaky skin. It can also actually still be highly vascularized, and you have to be very mindful of like with your any mechanical debridement, you're going to have to be careful. And then also with hyperkeratosis, you're at risk of fungal infections due to moisture. Another lymphorrhea, don't forget, this is a great picture. Abnormal flow of the lymph that drains externally from the disruptive lymphatic vessels, or that's coming out of a wound. And then this, I mean, I've never seen this, that theoretically, if you had a surgical dissection that wasn't closed appropriately, maybe the lymph is draining directly from the lymphatic vessels, but it's more a manifestation that I see of uncontrolled lymphedema is the lymphorrhea. Um, So, like I said, it's really about training your eyes. And so, like I said, the kind of one of the schools of thought is that everybody who has chronic venous insufficiency, also by definition, has lymphedema because of the concurrent embryologic development. Also, we can have swelling with people who have varicose veins or chronic venous insufficiency. So part of my workup usually is a vein referral if the patient hasn't had one already. And there's lots of good vein groups in Grand Rapids and Western Michigan. So some things to remember to be on the lookout for. So top left, that darkening, that's a hemosiderin deposition. Bottom left is your kind of venous eczema, venous dermatitis. Top right, it's white, so that's an atrophie blanche, or like blanche is right French for white. So it's kind of how scarring looks. The scarring looks white like that. And then on the bottom right, there's two images. One is that leg ulcer, like a venous leg ulcer. In a non-pressure location. And then that's the bottom is the lipodermatosclerosis, which I learned in medical school, but not everyone is super familiar with this phrase, the inverted champagne legs. And you can see it gets narrow because that's the sclerosis, right? So, okay. So 90% of diagnosing lymphedema is in your history and physical exam. And I also really, tell trainees also that the value that you're adding when you're doing clinical lymphology is really elucidating for the primary team or the referring provider, like what is the etiology? Typically for cancer related lymphedema, it's one thing. It can be two things if they had the dissection and they also had radiation, but typically non-cancer lymphedema is almost invariably multifactorial. So the gold standard for imaging or diagnosis is lymphoscintigraphy. You can do MR lymphoscintigraphy. But it's not going to change your management. So I order it very rarely. It can be done locally. Corewell Health will do a lymphoscintigraphy. I do it in kids, which I think is important to be like, especially for primary lymphedema. And I do it for patients who are very like, they must know. They are like very like, I need the whole kit and caboodle in terms of having their workup. But like, I can tell you I probably ordered it less than 10 times in 4 years because really, truly, this is clinical and you know what you're looking at. Um, uh, Indocyanine green, which I don't think we can do locally, is a bit comparable to the nuclear lymphoscintigraphy. It will show you the subdermal lymphatics. It will kind of capture secondary lymphedema at an earlier stage. I think they're doing a lot more indocyanine green in like Australia, New Zealand. Has a specificity 97%, sensitivity 55%. It's less invasive, it's lower cost. But I'm not doing that. I don't think people are doing that around here. Remember, your differential, and by, differential. So what is contributing to the swelling? Is there, organ failure? Is there a systems failure? And some people say that, Yeah, it's called like a high output failure. So um, some people say, well, that's not lymphedema. And like ultimately it is though. It's just saying that they're, and if you have the high output failure, so for example, if you have chronic kidney disease, chronic heart failure, chronic liver disease, um, if your system is actually having to deal with high output for so long, it will eventually develop secondary damage anyways. So you will have true secondary injury and secondary lymphedema. Um, so typically for me, a patient who has non-cancer related lymphedema, I would say the patient has, stage 2A bilateral lower extremity lymphedema in the setting of supramorbid obesity, CKD, and CHF, for example. And that's kind of how I bring it all together. Um, I'm always, before they get here, obviously, before they get to clinic, you want to do your chart review. You're looking at the CBC. Maybe there is like a white count. Maybe they already have cellulitis, CMP, right? You're looking at your creatinine clearance, BNP, echo. Are they having a workup for heart failure? A duplex, right? You want to rule out a clot, also particularly patients with cancer-related lymphedema. Make sure you're ruling out a clot. And then, like I said, I do a vein, typically as primary, I do a vein consult. And then it's like, if there's anything interventional for the vein specialist to do, they do it. If they need to do stripping or ablation, they do it. And then whatever's left over, you can manage with lymphedema therapy. Um, uh, So this on the left, you're going to see a parameter that's a lot more in research. So this is how you're going to be measuring and comparing, limb size. So parameter, like I said, is more for research. It uses LEDs, this like perpendicular light curtain in a frame, and it's kind of giving you contoured images, which you can quantify. Um, and then what the lady has in the middle, which we're kind of in talking about, Mary Freebed is getting doing bioimpedance spectroscopy. So it's called an LDEX. She has her hands and her feet on the pads, and it's the bioimpedance with like a low level electrical signal. So more fluid makes it easier for the signal to travel. It is obviously helpful to have like a pre-surgical or pre-radiation baseline measurement for sure. Tape measure circumference, which is great, was what you can do in the office. So lymphedema therapists have their technique of doing it. They're usually going up by, 8 centimeters at a time, distillate approximately. That's a lot of measurements. What I've been doing is the metacarpals, the wrist, and then 10 centimeters below the elbow and 15 centimeters above the elbow, and you compare right with left. Water displacement, also more of like a research tool. So we're kind of gonna talk a little bit about cancer-related lymphedema. This population, I think this population we're going to kind of say is really at risk of kind of misinformation. But this is, I think, helpful for some of our younger trainees, or earlier career trainees, earlier career physicians, myself included, that we kind of take sentinel lymph node biopsy for granted. But actually, they had to prove that sentinel lymph node biopsy was still as safe and curative as axillary lymph node dissection. So axillary lymph node dissection, which used to be used far more commonly, and you just take, up to like a dozen lymph nodes from an axilla, has a very, very high risk, up to 40% risk of lymphedema, versus sentinel lymph node biopsy. You only have to take like a couple of lymph nodes. These patients have a lower risk. What I've seen in the literature is less than 4 lymph nodes, your risk is less than 8%. So they had to do the trial. So one trial was 5,600 women, and they did sentinel lymph node biopsy or sentinel lymph node plus axillary lymph node dissection. And they were followed for about 8 years. And there was no difference in overall survival and disease-free survival, which was great. So really, this is going from an axillary lymph node dissection to the sentinel lymph node biopsy. It was a surgical technique that really reduced the incidence of lymphedema. So a lot of what we kind of, a lot of what particularly women, but also men, hear about is, the precautions if you have lymphedema or you're at risk of lymphedema. And I do think we have to, especially as, palliative, quality of life specialists say, what does it mean to give someone some really strict lifestyle precautions like air travel? They survive cancer, maybe they want to go on a nice trip. Um, and also your risk, what are you saying to a patient when you're like, that whole arm is off limits? Um, so they're kind of the psychological burden, this anxiety, and often it's unnecessary. Um, Precautions should be evidence-based, not just based on kind of what we've always done. And they did a survey of almost 1,000 women, and patients perceive the risk as very high, which really, within 1,000 women surveyed, probably their risk was very heterogeneous. Some of those women had pretty low risk, and some women did have high risk, and like everything in between. And that the majority of them said that the precautions, the guidelines really negatively impacted their life post-cancer treatment. So the precautions with limited or without evidence base include avoiding the blood pressure cuff on the at-risk arm. I don't have to take you through every single study, but so look at that. You can see all your p-values are not significant. So there's no level 1 or level 2 evidence to suggest a relationship between ipsilateral blood pressure measurements and arm swelling. What about avoiding venipuncture or lab draws? Skin punctures, lots of studies, skin punctures do not cause lymphedema. You can see there's multiple authors, multiple years. The actual, I don't know the number of lab draws that we do in the US on a daily basis. I mean, easily hundreds of thousands. The actual risk of getting an infection from a needle from a lab draw is 0 to 0.5%. It's very, very low. Avoiding air travel with or without compression garments. It comes from this study that was like level 4 evidence. It was 6% of the patients retrospectively, so there's that kind of like recall bias, linked the onset of swelling to air travel. So underneath it, different study, 94% of patients did not have any statistically significant change in extracellular fluid relating to air travel. So there's nothing really there either. Also, something to be said, though, if you're wearing a poorly fitting compression garment. So some people are like, well, I should wear a compression garment when I travel. Just wear anything. And that's definitely not the case. If you wear a poorly fitting compression garment, that will make things worse. Plus, it puts your skin at risk, right? So in summary, there's not enough data to justify recommending strict adherence to avoiding skin punctures, blood pressure measurements, or compressive garments for air travel. Or use of compression garments for air travel. If you have one, so I said, if you have a compression garment that's been fitted, that's like your daily routine, you wear it while you travel. If that's not part of your swelling management, you don't just wear one because you're air travel. You don't have to do that at all. There's no evidence to support that. There is a very excellent review article about all of this. I am also as part of the reading I provide to trainees. It's from the Lancet Oncology 2016 that goes into all of these topics. So what are evidence-based precautions? Maintaining a normal BMI, so avoiding excess weight gain, having a regular diet, a healthy diet, kind of plant-based diet, regular exercise, resources you can provide your patients, a dietitian, PT/OT, community exercise programs. Um, interestingly, Interestingly, I was listening to a lipedema, so right, the abnormal fat deposition. It was like a lipedema lecture at like a virtual summit, and there's some research into Mediterranean low carb, high fat diets for shifting lipedema weight. So that was super interesting. That being said, I think the authors will look conflicted because the kind of high fat, low carb diets aren't really healthy long term. So, but like I said, that's for people with lipedema, but interesting. I mean, ultimately what I'm invariably recommending is, a plant-based diet. And I really like the Dr. Greger's Daily Dozen. I think we actually might come to that at some point. Yes. And then avoiding infection cellulitis with first aid, appropriate skin and nail care. So I really hammer it home to patients. I want them moisturizing on a daily basis, which, like seems like a frivolous recommendation, but it's like dry skin gets cracked and is a nidus for infection. Moisturized skin is supple and has lots of give and is just more resilient. So moisturizing on a daily basis. If they have wounds, the wounds need to be addressed very seriously. And then podiatry, I send so many people to podiatry because, like, if you have really bad nails, like onychodystrophy, onychomycosis, that can also be a nidus for infection. And obviously that's attached to your limb. So it's going to make your lymphedema worse. The sauna is a little bit of a mixed, there is evidence that you should avoid sauna. I think it would be different if I worked in Scandinavia, I think, where people maybe do sauna, almost on a daily basis. I don't have patients in West Michigan, particularly doing sauna every single day. Some patients really like their hot tub, and in those kind of patients, I would say find a balance of quality of life. I think the evidence is a little more on the mixed side compared to some of the other stuff. So I'll say, like, if you were gonna do the sauna, once a month, or do the hot tub once a month, like, because it really brings you pleasure, go for it, that kind of thing. So, like I said, be mindful of the impact that these precautions, these recommendations have on a patient's life and quality of life. And then also, to go back to the venipuncture and the blood pressure, what I say to patients is when staff need to do something, say, like, try my unaffected arm. And if that doesn't work, after one or two goes, we'll switch to the affected side. But, the affected side is not completely off limits. I don't want them trying the unaffected side 14 times and still not, if you need labs, you need labs. If you need accurate blood pressure measurements, you need accurate blood pressure measurements. It's okay to use your affected limb. And even especially with blood pressure, like, it's very inaccurate doing it in somebody's leg, right? So you really want like an upper extremity blood pressure measurement. So sorry about the barking. Weight management approaches, like I said, I see a lot of patients with obesity related lymphedema. I don't even bat an eye anymore with a BMI of 40, BMI of 70. I have seen a lot recently, and that's very, very challenging. And I think having an open conversation, these patients have thought of this before. You're not the first person telling them that weight management needs to be addressed. And I had a patient actually thank me recently that I was asking her about weight loss and weight management, because she said her primary care doesn't ask her. And I kind of sorry, the haiku never stops. Typically questions I ask if someone has like a very high BMI is, have you ever lost a large amount of weight in the past? How did you do it? do you prepare your food? Does someone else in your home prepare the food, or do you eat out? And then, what did you have for dinner last night? I think are good kind of screener questions. Um, Bariatric surgery is right for the right patients. So some patients have had it and then it didn't work, or some patients thought about it and then life got in the way. So it is important to, just see if that has ever come up for the patient. There's lots of good apps. MyFitnessPal, Noom. They don't pay me to say that. I just know that my patients and even people in my family use those apps. Dr. Greger's Daily Dozen, it has a free app, and it also has like a really good visual that you can print out to give to your patients that you can just get off Google. And then the book I recommend, which I get a lot of positive feedback from patients, I always say it's $20 on Amazon. They don't have to buy it. But if they want like a reference to have at home, that one at the bottom is the one I recommend. It's a nice slim volume. It's a good patient level. And like I said, it's a better price point. And I think it has that very like lifestyle medicine approach. It has 50, excuse me, has 50 recipes at the back to kind of get people inspired to have kind of more healthy diet, more plant-based diet. All right, I think we're good. So your gold standard for managing lymphedema is complete decongestive therapy. And this is kind of four-pronged, five-pronged approach. You have to have a certified lymphedema therapist, which can be anybody. It can be a PT or an OT. There's physicians who get trained. But what you're doing is the manual lymphatic drainage. Then you're doing the short stretch wrapping, which are not the same as ACE bandages. They have very minimal elastic, so short stretch wrapping, skin and nail care, right? Because we talked about the risk of lymphedema, of cellulitis. Special exercises for the arms and the legs. There's also abdominal breathing, which are these different hand placements for patients to clear those deep abdominal lymph nodes. So when you clear the more proximal lymph nodes, then the lymphatic system can receive the fluid that you're moving distally to proximally. And then you obviously want to give education to patients. So you want to tell them what are the evidence-based precautions. And then you actually, as a therapist, you're doing the manual lymphatic drainage, but then you're also teaching patients how to do the massage themselves and how to clear the lymph nodes themselves long-term. So I would say to patients, there's the active therapy and there's a maintenance therapy. The active therapy is what you do with the therapist, and the maintenance is what you do for yourself to maintain those positive benefits for the rest of your life. So you can see the image on the top right. Bottom right is kinesiotaping. There is weak evidence to support kinesiotaping plus complete decongestive therapy. But some patients really like it. And I have this algorithm for, if you recommend something that has weak evidence to a patient, it should be affordable, non-invasive, and something they can do for themselves. And kinesiotaping is a 3 for 3. That it fulfills all those criteria. So if patients are into kinesiotaping, I'm okay with it. Our therapists at Mary Free Bed don't do kinesiotaping, but Trinity Muskegon were like super into kinesiotaping and teaching patients how to do it. And as you can see, there's an anchor, and then there's the fingers. So the fingers, you want the fingers to be going towards the anchor, and the anchor is more proximal. So that's kind of the direction that you want the lymph to be flowing. And kind of the theory, so to speak, is that the kinesiotape is pulling on the skin and giving a little bit of more space for the lymph vessels and the lymphatic flow. So make of that what you will. The big thing with the K-taping is showing people how to take it off safely. You cannot rip it off. You will rip your skin. So it's only for the right kind of patient population. And mostly honestly, for patients with upper extremity, more breast cancer related lymphedema. The legs are tricky and different. Okay, so wrapping versus custom garments. So that active phase of the active phase of treatment, when you're working with a lymphedema therapist, you're doing it almost every day of the week. So we do about 4 days a week at Mary Free Bed, Trinity. Last time when I was working with them, they were doing it 3 days a week. But it's pretty frequent. Like I describe to patients as a burst of therapy. The goal is, the reason you're doing it so frequently is that every time they're trying to make the circumference of your leg smaller, your arm smaller and smaller each time. And like I said, we're using those short stretch bandages. So usually you have to order those, you meet the therapist, they either provide you with the bandages or you order this special, like they're not ACE bandages. And the reason they're short stretch, they're low elasticity, is because when the therapist is doing the massage and then wrapping you, it's like they're creating a wall. Because if you had elasticity, then the fluid, right, would just push out against the elastic. But if you have no elastic, it creates a wall to keep the lymph back in the system, right? And so when I had my kind of postpartum, I mean peripartum lymphedema, I actually had one of the therapists come wrap me every single day for 4 days in a row, to really kind of get everything jump started with kind of diuresis and getting the fluid off my legs. And every day I could see they were getting smaller and smaller. But then long term, so at the end of your therapy, so maybe you've been doing it 4 days a week for 2 weeks, your limb is at its smallest size, and then you're getting elastic garments, either custom, which you have to really prove to insurance that you would benefit from custom garments versus off-the-shelf garments. And that's what you wear during the daytime. You don't wear elastic garments at nighttime because you don't, there's gravity exerts different effects at nighttime. You also don't want to risk a tourniquet effect on your limb overnight while you're sleeping. So, there's special nighttime garments, and a lot of people actually wean off of nighttime compression. Um, so, that's a good thing. This was a top left is a blog, a lymphedema blog, and she called herself Lymphosaurus Rex. And I believe the far left is her nighttime garment. Yes. And yeah, nighttime. And then the top right is so that's those are Velcro garments. They have different brands. You'll hear different names, but if you Google it and you see Velcro, okay, it's a Velcro garment. These are good. These are good for more elderly patients or patients who are going to have difficulty with donning and doffing. The elastic garments, the maintenance garments are really hard to get on. I do try to offer people, because I think they don't get it very much, like the sock donners, the metal frames that you can load your compression garment onto. You can get that from, like, if your doctor orders that and sends it to CareLink. That helps a lot of people, but some people, you'll have patients where you're like, there's no way they're gonna get an elastic stocking on. So those are patients who the Velcro is not as good, it's not as compressive, but it's fine. You gotta do what you gotta do. I say the best compression is the compression that your patient is wearing consistently. So the Velcro garments are good. There's also, this one, it just shows the calf, but there's bits that you can put on their foot and on their ankle. And actually the Velcro ones you can wear overnight. So actually I have a patient who's a firefighter, and they do 24-hour shifts. And he's like, sometimes I'm sleeping, but sometimes I'm working. So what should I wear? And we were like, actually, probably Velcro would be good. Because then if you're having a rest, you have a rest. And if you go to do some firefighting, you're ready to go. So that's what I also like about doing a lot of lymphedema, is you see a lot of different patients. You have to do a lot of problem solving. And it's very stimulating. So we're almost at the end, and then maybe if we can talk. Oh yeah, we're running out of time. Okay. I'll just have some other quick pearls about managing some interesting populations. So, advanced pneumatic compression device, I describe it to patients as like the cherry on top or the icing on the cake. If we can get it for you, that's great. And I send referrals a lot and try to get this for a lot of my patients. If they can't get it, though, I say it's not the end of the world because these patients should still be doing their daily massage, lymph node clearing, compression, plus they do the pneumatic compression device, which the standard clinically and kind of industry wise, about an hour a day is appropriate. So you can get single compartment, non-calibrated, no gradient, or multi-chamber calibrated with a gradient. You're trying to either mimic the venous system or mimic the lymphatic system. It's almost like, almost like a robot lymphedema therapist. I'm going to tell you all of the literature is mostly industry sponsored. So obviously there are limitations. So bear that in mind. That being said, some of the stats are that it can reduce limb volume by 8% or 1,100 mils. That's a lot. There's one study, like I said, it is biased, but it did impress me. It was a retrospective chart analysis of an insurance database in Minnesota, over 700 patients, both cancer and non-cancer related lymphedema. And actually reduce the incidence of cellulitis by 75% in both groups. And I've seen that play out. I have patients who say, I haven't had cellulitis since I used my pneumatic compression device, which is really good. And then it also reduced the need for the patients to go for like lymphedema therapy top-ups. It reduced outpatient appointments, it reduced spending, it reduced like healthcare spending, and this was all statistically significant. So I do like to try to get this for patients. You should pick a company that you want to work with. It just kind of makes it easier. I work with Tactile Medical. They don't pay me. They're just, like I said, very easy to work with, and they'll try to really work hard to get the device for the patients. And like I said, it's an add-on. It's not instead of, it's a both and. So I think that is the end. So maybe some other interesting things. So one of the things to bear in mind with the active treatment with the lymphedema therapist is the patients you're trying to pick who are appropriate for lymphedema therapy are ones who are either going to be able to wrap themselves, because they're going to have to wrap themselves on their off days, right, when they're not seeing the therapist, and so they need to be able to reach their legs, wrap their legs, and then also learn the like massage techniques, the lymph node clearing techniques. So they have to do themselves or a loved one who's going to commit to coming for all of the appointments. So that's not, that doesn't suit all patients, right? And those other patients, and it's also very difficult for patients in facilities, and that kind of breaks my heart sometimes because there's no easy answers. Some of those patients, some of my solutions are, there's a few things. You could just get them a Velcro garment, and the Velcro garment won't make their lymphedema better. So giving somebody a garment won't make their swelling better, but potentially it'll prevent it from getting worse. So those patients, it's like you're going to give them the counseling about the moisturizer and the elevating and getting a podiatrist. And then you get them the Velcro garments, and they're just really not candidates for the complete decongestive therapy. Other things to consider that this was a recommendation actually from my wound colleague is Cetopress. Cetopress, it's a kind of compressive wrap you can get from CareLink or like a medical supply store. And like it's SETO, and it has the rectangle. And if you pull it to the right tension, the right compression, the rectangle turns to a square, and you know that you're wrapping at the appropriate pressure. And you can get your patients like 2 sets, right? Because you want them to be wearing one that's clean, and then the other set will be in the wash. And you could do the Cetopress. That's like an option if they really can't come. Obviously transportation is also an issue, like getting getting to Mary Free Bed or getting to Trinity or getting to Holland. Not everyone can do that either. There is a therapist that I've now become familiar with. There is a PT in Grand Rapids who's doing home lymphedema therapy. As far as I know, he's the only guy. Um, and I actually have a couple of patients with ALS who have pretty severe lymphedema. So one of them was getting home lymphedema therapy. The other one I was trying to connect with this home therapist. Um, and um, and then also with the patients who have ALS, really trying to get them the pump as well. And if they have a caregiver who can put the pump on, that's the other thing with the pump. It's also not easy. So you have to be able to put it on, or you need to have a consistent caregiver. Um, and also I say like the best regimen is the regimen that you can do consistently. So like I had a patient recently who the family was going to help them once a week. And I'm like, once a week's not worth it. It's just simply not worth it. So I would say, honestly, if a patient can be wrapped 3 times a week, I would say that's the bare minimum to make any, like if a caregiver could wrap them or put their pump on 3 times a week, it's probably worth it. 1 time a week, don't like blowing in the wind. So yeah, I have some patients with ALS. I have some patients with cerebral palsy. If they're wheelchair, they're in a dependent position for long periods. I have patients with cerebral palsy. I have patients with multiple sclerosis. Some children have, particular syndromes. So you're thinking like Turner's, Noonan's, tuberous sclerosis. Those have associations with primary lymphedema. I think, palliative hospice populations. And maybe I'll leave you with this, and if there's any other specific questions, for like 2 minutes, but, there's no role for diuretics, in regular lymphedema management because it pulls the fluid and it leaves the protein and actually can kind of make that fibrous deposition worse. So there is no formal role for diuretics. If you have a patient who is a lot closer to end of life or a very serious illness, life limiting, do the diuretics. Like I would for sure. You could even do the what is it, like the chemical paracentesis, or like just like do a very aggressive diuresis if it's going to help them, if it's going to make their legs lighter, go for it, right? And then in those patients, you know whatever you want to try. I think, if you want to do the Velcro garments, great. If you can reach out for a pump, also, and they have someone who can put it on for them, great. The Seto press, like those kind of compressive wraps they can do for themselves. If they had a caregiver, that would be an option if you can't be transporting them to a clinic. So I think I kind of at some point I'm hoping to maybe make an algorithm of like things to consider in patients who have advanced disease or life-limiting disease who also have um lymphedema. So, the complete decongestive therapy, it's the gold standard. It's the textbook. We all know that life is different. Patients are unique and have unique challenges. And I think, being that kind of patient-centered provider, you're trying to find unique solutions for each of your patients. So ultimately, we want to empower our patients to live functionally and independently despite having a chronic lifelong condition, and to lower the risk of lymphedema associated complications. So thanks so much.
Thank you, Naomi. That was a wonderful lecture. I learned a lot in that one myself. Growing up in the osteopathic tradition, when we would have our OMT classes, labs, the repeated message again and again was open up the lymphatics, open up the lymphatics. Do you see much role for osteopathic manipulation in lymphedema like this?
Oh, that's a great question. um, because I'm an MD, but as a physiatrist, I wish I knew more about osteopathic manipulation. So it's not something I've delved into, but now that you've kind of shared that, I will certainly, and we do have some of our trainees and some of our attendings at Mary Free Bed are DO. So that's definitely something I could talk to them about. But something that you said, like opening up the lymphatics, like, and just do it. And I think one of another kind of paradigm shift recently has been, you know, should we just say that all swelling is lymphedema because the lymphatic system plays such an integral, it is really the primary driver of fluid transport and fluid movement. Much more so, the veins used to, we were taught it's the veins, but really it's the lymphatic system. So that's kind of right now, that's kind of the approach that I take, is that all swelling, can really be considered to some degree lymphedema. So really that emphasis on having, a functioning lymphatic system makes sense.
Good. Are there any other questions? All right. Well, thank you again, Naomi.
Yeah. Please reach out with any questions, or if you have any cases you want to run by me, always happy to do some, troubleshooting or problem solving or provide any help that I can.
Sounds good.
Thanks so
All
much.
right. Thank
Take
you.
care. Appreciate it. Bye.
Bye-bye. Thanks, Dr. Cameron.
Thank you.